everyone. I'm Dr. Sana Noman, working in radiology in Bahrain Specialist Hospital. Today, I will give a talk on an interesting topic that we came across recently due to a case which presented in our hospital. It is focal nodular hyperplasia and focal nodular hyperplasia-like lesions encountered in cirrhotic patients. So first, I would like to introduce the case that presented in our hospital. It is a 69-year-old male who had a long-term increased intake of alcohol, and on routine ultrasound was found to have a lesion in the left lobe of liver on the background of chronic liver disease. According to the patient, he has been undergoing yearly ultrasound, and this lesion was never reported to him. As the lesion was found on the ultrasound, he was subjected to a CT scan initially with triphasic protocol to characterize this liver lesion, which showed atypical lesion with characters, not any definite characteristic fitting into a focal characterization of the lesion, and hence was taken an MRI, which was also done outside and showed a 6 into 5 centimeter mass in the left lobe. The serum alpha fetoprotein for this patient were normal. Keeping in consideration the clinical disconcordance with normal AFP levels and a lesion newly developed in a patient who is showing background of cirrhosis, this patient was subjected to a biopsy, an ultrasound-guided biopsy, which turned out to show a benign proliferative lesion pointing towards a focal nodular hyperplasia. Before I proceed with the details of the lesion, I would like to discuss what focal nodular hyperplasia is and what is its importance when it is seen in cirrhotic patients. So FNH, also called focal nodular hyperplasia, is the second most common benign liver lesion after hemangioma, and it represents about 8% of primary hepatic lesions found. It has an incident rate of 0.9% and is much more common in females, with women to men ratio of about 8:1. It is most commonly diagnosed in the 3rd to 5th decades of life and usually presents as a single lesion. However, multiple lesions have been reported in about 20% of cases. Histologically, FNH is the hyperplastic growth of normal hepatocytes without normal development of the portal tract. A central fibrovascular scar is usually present, which contains a feeding artery with radiating fibrous septa containing malformed feeding arteries and branches. Most of the cases of FNH are asymptomatic and incidentally found. This lesion have no malignant potential, and the reported cases of complications like hemorrhage and rupture are extremely rare, with only a handful of reported cases in the literature. So the asymptomatic FNH does not require any treatment as such, and even does not require to be followed in a patient with no history of background liver disease. But when there is a known malignancy in a patient, or the patient has underlying liver disease, as in our case, even when we find the FNH lesion, we need to keep it under surveillance. So rarely FNH becomes symptomatic. And when this lesion becomes symptomatic, it is usually due to the size of the lesion and the compression effect or the mass effect it has to the surrounding liver parenchyma. And in those cases, selectively surgery or some other non-invasive treatment options can be done. Before I proceed to the imaging features of the focal nodular hyperplasia, let me just explain you briefly how the liver is imaged to characterize focal liver lesions. So we commonly hear the term triphasic contrast scan. The reason why we do triphasic contrast scan is because each lesion of the liver, be it benign or malignant, has a characteristic imaging features and behaves characteristically with the contrast and with the flow of blood. If we know the pattern of enhancement and how it behaves on different phases of blood flow, we can characterize each lesion into the categories of benign and malignant. So for doing this, we need to scan the liver at different phases. First, we have to give the contrast, and then we have to wait for the arterial phase, which begins from 25 to 35 seconds. Then we have to scan the liver at portovenous phase, and then on the delayed phase, we can see how this lesion behaves. So a benign or malignant lesion have characteristic enhancement pattern, and based on these imaging of the liver, we can confidently classify them into each of the category. When we do ultrasound, in contrast enhanced ultrasound, we don't have any blind window. We dynamically watch the lesion, how it behaves with the blood flow, how the blood flow is coming in and going out, and we can characterize the lesion dynamically without having any blind window. When we do CT and MRI, we have to phase this liver. We have to scan the liver at different phases. So we do have a small blind window, which may sometimes give a wrong lead towards any other lesion. Now, when we come to MRI, MRI has two subtypes of contrast. One is the regular contrast that we use, which is the extracellular contrast agent, which behaves just like the CT contrast or the usual ultrasound contrast. It goes with the blood flow and is accumulated in the extracellular space. In special, there is another contrast which is called hepatocyte-specific contrast agent, which can be used with when the image is done after 20 to 30 minutes of administration. And this contrast has a propensity to be accumulated in the healthy hepatocytes, giving a characteristic appearance, which is very important in diagnosing focal nodular hyperplasia. So what happens with the extracellular regular contrast agent? It goes into the blood flow, and we can scan the liver in the different phases of arterial, portal, venous phase, and delayed phase, like we do in regular CT and MRI, and they are not taken up by the hepatocytes. The hepatobiliary contrast agent, which is a specific agent, it goes into the blood flow and gives the same dynamic appearance of arterial, portal, venous, and delayed phase in the initial phases. Later on, after about 20 minutes of contrast administration, it is taken up by the hepatocytes by special membrane transport protein, which transport this contrast agent into the hepatocytes. And eventually, it is excreted through the bile into the common bile duct and in the bowel. So this contrast agent can be studied dynamically in the initial phase, and later on, after 20 to 30 minutes of the administration, it gives a characteristic bright appearance to the liver cells, and certain lesions who contain healthy hepatocytes like FNH, focal nodular hyperplasia, will light up with this specific contrast agent, while other benign or malignant lesions will not light up. Okay. So, sorry, there was a glitch. So typical imaging features for FNH is that it is a solitary, well-circumscribed, unencapsulated, lobulated lesion that usually measures less than 5 centimeters. And because it is mainly composed of hepatocyte, it appears similar to the background of liver on unenhanced images, and therefore can be missed on ultrasound. Color and power Doppler ultrasound improve its visualization, and with contrast-enhanced ultrasound, the typical spoke wheel and feeding artery can be seen, which I will show you subsequently. On CT and MRI, it has a characteristic appearance of early phase hyper enhancement on the CT scan and MRI, which on photovenous and delayed phase, it becomes similar to the background liver. So this is a focal nodular hyperplasia being displayed on a contrast-enhanced ultrasound. So in contrast-enhanced ultrasound, we target the area of interest, give the IV contrast, and dynamically study how the contrast comes in and how it behaves on delayed phases. So this is a feeding artery which is coming into the lesion, and a branching pattern can be seen. There is homogeneous enhancement of the lesion, which becomes similar to the background liver on delayed phases. So this is characteristic feature of a focal nodular hyperplasia. On CT scan, sometimes we can see the feeding artery on early arterial phase, but usually this phase is skipped in routine CT scan. So we see hyper enhancement on arterial phase with central non-enhancing scar, which on delayed phase becomes enhancing with similar appearance to the background lesion of the background liver for the rest of the lesion. So initially on the arterial phase, you'll see a central non-enhancing scar, which will eventually bright up on the photovenous or delayed phases. On MRI also, it has characteristic appearance, and where it can be diagnosed confidently. It shows on T2 weighted images, pre-contrast, it shows a bright central scar with almost similar appearance to the background liver on plain scan. On contrast scan, it behaves exactly like it behaves in the CT scan. There is acute hyperphase enhancement, arterial phase enhancement in the periphery with non-enhancing central scar, which eventually lights up on the delayed phases. The hepatobiliary phase imaging of the liver, which is done by hepatocyte-specific contrast agent, it has a characteristic appearance for FNH, and it is usually done where the clinical question is between FNH and any other benign or malignant lesion. So the FNH has a typical pattern. It appears mostly bright on the hepatobiliary phase, which is 20 minutes after the giving of IV contrast, while the non-FNH lesions, although they may take up some of the contrast, but their appearance is usually central uptake with the periphery being spared. However, the FNH has a specific enhancement pattern, and all the lesions which bright up in this hepatocyte-specific contrast agent in the hepatobiliary phase can be confidently labeled as FNH in the usual settings. Histologically, a central scar is composed of the fibrous and myxomatous elements. That's why it enhances on the delayed phase. However, this scar may be seen only in 60% cases of CT and 80% cases of MRI. However, in the histopathology, they are seen on all cases. A large feeding artery, like I said, may be seen on CT and may not be seen, but in contrast-enhanced ultrasound, it will be seen very confidently. Now we come to the controversy, which is the FNH-like lesions. FNH-like lesions is the term applied to lesions that are macroscopically, microscopically, and immunohistochemically identical to FNH, but they occur on a background of abnormal liver. There are many conditions that predispose patients to form these FNH-like lesions, and all of these lesions have they are because the underlying liver has a vascular disturbance. So they are basically a response to the vascular disturbance due to certain conditions which result in formation of these FNH-like lesions. As they're histologically identical to FNH, they have no malignant potential and they do not carry risk of hemorrhage or rupture. Therefore, they are usually left as leave-alone lesions. These are the conditions which predispose to the FNH-like lesions: abnormality of hepatic outflow, in which the hepatic venous flow is obstructed, like in Budd-Chiari syndrome or in certain surgical procedures; abnormality of hepatic inflow, like portal vein thrombosis, absence of portal vein or cavernous transformation; and in hepatic microvascular disturbance, which is the topic of interest today, that is the cirrhosis of the liver. FNH and cirrhosis of the liver is quite a known abnormality, and it poses a diagnostic challenge, which we will discuss subsequently. Cirrhosis of the liver is the pathologic result of chronic liver damage with necroinflammation and progressive fibrosis. Accurate imaging evaluation is important because patients with cirrhosis are prone to have hepatocellular carcinoma. As hepatocellular carcinoma can be confidently diagnosed on imaging and there is no requirement for biopsy as such, a radiologist must know the characteristic imaging features of hepatocellular carcinoma and this FNH-like lesion, so he can confidently differentiate between these two. Having said that, the overlapping features and the atypical behavior of both the lesions should also be well known by the radiologist, so there is no misleading diagnosis in such cases. FNH-like lesions are thought to form because of the altered vascular dynamics of cirrhosis, including sinusoidal remodeling, local ischemia, and angiogenesis, and formation of intrahepatic shunts. These lesions, unlike dysplastic nodules, do not undergo malignant transformation and therefore should be left alone. Histologically, they can be challenging to distinguish from well-differentiated HCC. So not just radiologically, even histology, they are very challenging and they may appear similar to well-differentiated hepatocellular carcinomas. And there is a study that reports that about 6.5% cases of FNH were misdiagnosed as HCC on percutaneous needle biopsy. There are even case reports vice versa, in which the cases were diagnosed as FNH and eventually turned out to be HCC, which we will discuss. Now, diagnostic imaging features of hepatocellular carcinoma and cirrhosis are arterial phase hyperenhancement, venous washout, and a presence of a capsule. FNH-like lesions can be difficult to distinguish from the hepatocellular carcinoma because they share the common feature of arterial phase hyperenhancement, especially when they are smaller than 3 centimeters. And although venous washout is not a typical feature, and this capsule is also not a characteristic feature, in patients with cirrhosis, a minority of cases of 6 to 10% have displayed this feature, confusing the diagnosis. One study also found that about 33% of FNH-like lesions were misdiagnosed as hepatocellular carcinoma at imaging, and only on subsequent biopsy, these were found to be FNH-like lesions. So this is a challenging lesion, which behaves like an HCC on imaging at times, a small percentage of time, and creates a diagnostic dilemma. With the use of hepatocyte-specific contrast agent that I introduced in MRI, these lesions in patients with cirrhosis typically demonstrate bright or similar enhancement to that of the background liver because they contain hepatocyte and the background liver also contain hepatocytes. So this contrast agent is taken up by these two areas, the normal liver parenchyma or the background liver parenchyma and the FNH itself. So on the delayed phase, which is the hepatobiliary phase in the MRI, which is about 20 minutes after the IV contrast, these lesions either they light up or they become same in intensity to the background liver. But however, in 30% of cases, these lesions in cirrhotic patients may appear dark, again confusing the imaging scenario. Further confusing the issue, about 6 to 15% of hepatocellular carcinoma may overexpress hepatocyte-specific membrane transport protein, which is responsible to carry this contrast inside the cells, and may light up on this hepatobiliary phase. So a fraction of FNH may behave like HCC, and a fraction of HCC may behave like FNH. So we know that there are overlapping imaging features. So now in this scenario, how we can differentiate between these lesions in the cirrhotic patient? Ancillary features including appearance of the lesion in T2 weighted images, considering diffusion weighted images, and the typical enhancement pattern, we can diagnose one lesion, we can weigh one lesion over the other lesion. But of course, this is a challenging case, and it will always pose a challenging dilemma. This is a case of focal nodular hyperplasia and FNH-like lesions, in which they try to find the characteristic imaging features of these lesions in cirrhotic patients. They found that most of the FNH, they did not show washout, which is one of the characteristic feature of hepatocellular carcinoma. Also, they found that diffusion weighted images also may help differentiate between these two lesions. In a study which evaluated hepatocellular carcinoma and FNH-like lesions in the hepatocyte-specific contrast agent, they found out that washout during the venous phase was the most accurate predictor of HCC, with 90% sensitivity and 100% specificity in a small sample size. Another study showed that a lesion size less than 1.6 centimeter, signal hypointensity, that is no diffusion restriction, and no washout, lack of portovenous washout, were independent predictive factors for FNH-like lesions. And if all these criteria, like size less than 1.6 centimeter, no diffusion restriction, and no venous washout is present in a lesion, it can be confidently diagnosed as an FNH-like lesion, even on the background of cirrhosis. Given the potential imaging overlap and the prevalence of hepatocellular carcinoma in patients with cirrhosis, LIRADS, which is a liver imaging reporting and data system, which has been proposed by American College of Radiology, it advises that even typical FNH lesion should not be labeled as benign or probably benign in a cirrhotic population, and it should be labeled as an intermediate probability, even though it shows the characteristic feature of FNH on imaging. And with patients with cirrhosis, where LIRADS cannot be applied, these lesions, although appearing like FNH, should be kept under surveillance, and they should be closely imaged at regular intervals. Now, this is a study which was published in January 2026, where they tried to find some characteristic features which could differentiate these two entities on a cirrhotic patient. So they composed of total 11 patients, in which 5 patients were focal nodular hyperplasia and 6 patients were cirrhotic hepatocellular carcinoma. They shared the similar imaging features, and then they retrospectively tried to see any difference between these two entities. They were all biopsy proven FNH or HCC, but initially in the imaging, they were reported as similar findings as HCC. So this is one of the lesion which was reported as HCC initially because of its enhancement pattern. And this is the hepatobiliary phase, which is taken after 20 minutes of the contrast agent, where they are appearing as dark. This feature is not a characteristic feature of FNH, and hence based on this, it was labeled as an HCC. Again, another lesion, which was FNH, finally diagnosed as FNH-like lesion, also appeared dark on the hepatobiliary phase, on the hepatocyte contrast agent, again labeled as HCC initially. This is a true hepatocellular carcinoma case, which is appearing dark as the characteristic feature of HCC. Now, retrospectively, they tried to find a difference, and they said that if the lesion appears, although it appears darker to the liver parenchyma, but if it is brighter than the venous tributaries, then it favors more of FNH than HCC. So in these two cases, or in all the 5 cases of FNH, they found that the liver, although it was dark to the background liver parenchyma, it was brighter than the venous supply. And in the hepatocellular carcinoma, 5 out of 6 lesions appeared darker not only to the background liver, but also to the venous supply. So this concluded that as all 5 FNH or FNH-like lesions were hypointense to the liver, but hyperintense to the intrahepatic vessel, that is, they were darker to the background liver, but they were brighter than the vessels, this feature may be used in future to differentiate these two lesions in diagnostically challenging cases. But again, this is a retrospective study, It is a small sample size, and more longitudinal studies are needed to confirm these findings and to further validate this data. This is a case of, it's a case report which is very similar to our case. It is a 68-year-old patient who had regular alcohol consumption and presented with incidentally found lesion on ultrasound on the background of chronic liver disease. This patient was subjected to CT scan, which showed characteristic feature of a hepatocellular carcinoma, that is arterial enhancement, and was shown portovenous in delayed phase. With these two findings, he was taken for surgery because biopsy could not be done, and it is subcapsular in location. And on histopathology, this was found to be an FNH-like lesion. So this case report indicates that perhaps the author says that if they had done pre-surgical imaging like MRI or dynamic ultrasound imaging to characterize this lesion further before subjecting him to the surgery, they may have avoided the surgery in this patient. But again, there is no definite diagnostic criteria which the LIRADS or any other community has still come up. Now, what is LIRADS? Just like we have BIRADS and TIRADS in the breast and thyroid respectively, the American College of Radiology, they brought some imaging features and they tried to characterize the hepatocellular carcinoma on cirrhotic patients. They came up with the liver imaging reporting and data system, which can be applied to the cirrhotic patients, which help in categorizing the hepatocellular carcinoma. The typical hepatocellular carcinoma features are non-peripheral arterial phase hyperenhancement, non-peripheral washout, presence of a capsule, size more than a certain size criteria is also applied, and threshold growth. These are 5 major criteria, which, if present in combination or alone, raises the suspicion of hepatocellular carcinoma in patient with chronic liver disease or hepatitis B. Then there are ancillary features which may upgrade or downgrade the lesion from the LIRADS category depending on their presence or absence. So the ancillary features which favor hepatocellular carcinoma are corona enhancement, which is enhancement of the adjacent normal liver parenchyma, perilesional enhancement in a typical pattern, mosaic architecture of the lesion, like it does not appear homogeneous on either on any of the sequence, and it appears mostly heterogeneous. Nodule and nodule architecture, which is again favoring HCC, presence of intralesional fat, and although enhancing capsule is a major criteria, non-enhancing capsule is a minor criteria for HCC. Features that favor towards benignity or homogeneous appearance, that is, there is less lack of heterogeneity. There is undistorted vessels present. Parallel blood pool enhancement, this is a characteristic feature for hemangioma. Diameter reduction, this is one of the features for FNH that on subsequent images it may shrink. Diameter stability more than 2 years, and in hepatobiliary phase, it becomes similar to the background liver parenchyma. These all features point towards benignity. This is how corona enhancement look on axial MRI images. Now, based on these findings, we can categorize the patients as LIRADS 1 or 2, which is the benign category, where you do not need to closely watch the lesion, and you can be confident that these 2 lesions are benign. Now, the LIRADS 3 is the intermediate category, which when the lesion is characterized, depending on ancillary features, it can be closely observed. And 4 and 5 are highly suggestive of hepatocellular carcinoma, where MDT meeting should be done and further management plan to be discussed through a multidisciplinary approach. So on the basis of criteria, they said if the lesion is less than 2 centimeters and does not show arterial phase hypoenhancement, it can be characterized in the benign category in the absence of other strong features. If we come to our case is more than 5 centimeters, so it is showing arterial phase enhancement. So it is characterized based on these 2 criteria only as LIRADS 4. The presence of enhancing capsule, peripheral washout, or threshold grade will upgrade this lesion to LIRADS 5. This is how the management plan works with each LIRADS category. So if it is LIRADS 3, you just need to repeat or you have to consider an alternative imaging if it has not already been done. LIRADS 4 needs multidisciplinary discussion and further workup, and LIRADS 5 should be treated as hepatocellular carcinoma and should be discussed in multidisciplinary meeting approach. Now, coming back to our case, these images, can we try open the other presentation? So our case showed a 6 into criteria of hepatocellular carcinoma, but this characteristic feature was seen in only one of the nodule, and the rest of the nodule was not showing washout. Reviewing the MRI images which were done from outside, we can see patchy areas of diffusion restriction. Remember, diffusion restriction is also a feature which is seen more in hepatocellular carcinoma and not an atypical feature for FNH. On T2 weighted images, we can see a heterogeneous lesion with lack of central scar, which appears bright on a regular FNH-like lesions. So all the imaging features in our case are pointing more towards hepatocellular carcinoma and is not favoring FNH on any of the imaging modalities that we have. Next, we are trying to subject this patient for hepatocellular specific contrast agent. So we can establish the hepatobiliary phase enhancement pattern, which will further guide us towards the diagnosis. Now, this is a case report which was published in the year 2025, in which they presented, the case is somewhat hidden. It was a 29-year-old female who had no history of chronic liver disease and was found to have a raised alpha-fetoprotein, was subjected to a CT scan which showed typical features for FNH. Based on the persistence high alpha-fetoprotein level, this was subjected to a biopsy. On the biopsy, she was labeled as FNH or FNH-like lesion. But because she was having persistently raised alpha-fetoprotein, the decision to take out this lesion was taken. And eventually on the final diagnosis, it was reported to be a hepatocellular carcinoma. Another case report was published again in the year 2025. This is a 59-year-old female who had chronic hepatitis C but was not yet developed cirrhosis. She was presented with a lesion on the left lobe of liver, 31 millimeter nodule, which showed again characteristic features for FNH, but was showing raised alpha-fetoprotein and was subjected to resection. In this case, no biopsy was taken, but on resection, the histopathologist found that the lesion was having coexistence of FNH and hepatocellular carcinoma in the same lesion. This case report was of a 65-year-old male. This was published in 2026 in in Journal of Oncology in Vietnam. It was a 65-year-old male who presented with a new lesion on the background of cirrhosis. The lesion was subjected on CT and MRI and showed typical features for hepatocellular carcinoma. Initially, a biopsy was done which favored a benign lesion like FNH-like lesion, and the patient was, because the patient had normal alpha-fetoprotein, although the CT and MRI features were more in favor of hepatocellular carcinoma, biopsy was done, and on biopsy it was labeled as FNH-like lesion. Subsequently, the patient underwent surgery because there was radiology and pathology disconcordance based on the size and the enhancement pattern, and this turned out to be a moderately differentiated hepatocellular carcinoma. This case study also did some literature review and quoted another lesion in an 86-year-old female who was also initially diagnosed as FNH-like lesion and later on surgery was found to have a hepatocellular carcinoma. So unfortunately, I cannot open the slide, but to conclude our case is showing imaging features which are disconcordant with the histopathology. Although histopathology points towards FNH or benign lesion, but our imaging features are strongly, till now, the features that we have are strongly indicating hepatocellular carcinoma. So I leave the decision on the multidisciplinary team to take the best decision in favor.
Doctora, I know yesterday you attempted hepatobiliary scan, but because of clips in the colon, we got a distorted image.
Yes.
Can we go to a contrast enhanced ultrasound dynamic study in this guy? Can we get ultrasound contrast in Bahrain?
We can try to get it, ma'am, and if we do it through EUS, it will be, I think, more beneficial because we'll have it is in the left lobe, we'll have a closer lobe, and the enhancement pattern can be picked up there.
I think that's what I would do, because these clips may last for a while in the patient. They may take up to a year to fall completely, but he had 15 polyps and he's on anticoagulants, so I couldn't risk not putting clips on the colon and polyps resected, because with anticoagulants they can bleed, even a delayed bleeding can happen. So I think the next study would be a dynamic study, and real-time ultrasound will be worthwhile using EUS.
EUS, yes.
Yeah. The question is, EUS, I mean, ultrasound ultrasound contrast is not easy to get, even in Europe. It is in low supply, but we try to get it for him.
Thank you, Dr.
Heavy smoker, very heavy smoker, has history of coronary artery disease. He's on anticoagulants, and 4-pack history, 4-pack per day smoker, until recently heavy alcohol. So we are dealing with multiple. His liver background is also not normal on the shear weight. It's on a borderline fibrotic liver. So this is why the decision was not taken to go for immediate resection.
What is alpha-fetoprotein?
It's normal.
It's normal, but we reported
Again,
2 cases.
Well differentiated. Hepatocellular carcinoma can have normal alpha-fetoprotein.
Actually, the last 2 case series that I found, they are very similar to our case, because radiology is pointing towards malignancy and histopathology, initial histopathology is pointing towards FNH. And they found that the whole lesion did not contain hepatocyte. They were coexistent HCC on a background of FNH.
I think what makes me worried about my patient is the inhomogeneous look of this lesion. Very inhomogeneous, so it has areas which are different enhancement than the rest of the lesion. When I did the vascular Doppler on his lesion, it is encircled with vascular pattern. The central area of arterial was not picked up for FNH. We didn't see a central Doppler signal. So it was all peripheral.
Even on imaging, we did not see any central hypoenhancing scar, which may be absent also, so we cannot take it as a diagnostic criteria.
It fits into that equivocal in every respect for CT, MR, ultrasound, and also alpha-fetoprotein. Nevertheless, I think anybody with a background of chronic liver disease, with hypertrophy of left lobe and atrophy of the right lobe, you have to consider this is HCC till proven otherwise.
And a new lesion also, which he says was never reported before.
Yeah. I only have 1 ultrasound for him in 1997 in my file because he never showed up back to our clinic since 97. And because at that point I advised him not to drink and he got angry with that advice and he never showed up back to my clinic. And that ultrasound I pulled out, it did not show a lesion. So it's not...
We had 1 CT dorsal spine plane done in the year 2023 for the same patient. But unfortunately, only a portion of liver is included. On careful comparison, there is no lesion obviously seen on this plain CT lumbar, but it's a limited view, so we cannot be sure.
Regarding LIRET's classification, so it's excellent criteria to distinguish between malignant and benign. The advantage is in more than 95% cases of LIRET's 5, we can safely avoid biopsy if it is LIRET's 5.
Yes.
But the main drawback is LIRET's category is the study is more validated in patients with pre-existing cirrhosis. So if you have a patient with normal liver, LIRET's criteria goes down. Second thing, it is less sensitive for tumors less than 1 centimeter, and LIRET's 1 and 5 can still be malignant if the lesion is less than 1 centimeter. So that is one of the drawbacks, that it might miss some of the patients of early HCC.
The advantage of a normal liver and a new lesion is if you resect that lesion, you still have a normal liver to deal with. But what do you do with a guy who has a compromised liver and you're going to block out a good amount of his liver, as you will end up with the liver failure story? Okay. And the comorbidity of cirrhosis for surgery. That's why we discussed this patient with Dr. Winkart and we decided no resection at this stage. If he is truly severe cirrhosis and with decompensated liver, you would say go for liver transplant. But he's not at this stage yet to say liver transplant, because liver transplant has its own morbidity as well. And we have to remember balancing the facts. So in extreme cases of full cirrhosis, go for transplant. Without metastasis, you go for transplant. For those who have normal liver, go for resection. Don't sit and wait to give the patient anxiety in equivocal cases. But for a midline story like here, where it is, yes, there is degree of liver disease, but it's not at the stage of transplant. I think what we will do also is give him a bit of time to quit alcohol, which he did now 3 weeks. He was able to stop alcohol for 3 weeks. Give him a few weeks without alcohol, reassess the lesion with a dynamic study, and if it shows that his liver is improving without alcohol, if it shows that this is highly suggestive of hepatocellular carcinoma, take the risk of the resection. What do you think, Dr. Noman?
By imaging, this looks like a frank cirrhosis. If we can open the imaging.
Yeah.
Yes, it does. But with the biopsy, Dr. Abid thinks that there is still a reasonably good liver architecture. I don't think it looks to me like a
No, just
liver
open targets.
architecture based on ultrasound, and on shear wave he is also borderline for fibrosis. Is Dr. Abid with us?
So imaging.
That's why I asked for biopsy from the normal liver as well, because I wanted to assess the potential for resection.
I mean, when we are considering liver resection, we don't take into criteria the biopsy from normal liver most of the time. In liver surgery, everything is by imaging.
Yes.
Everything is decided before surgery itself. We do mental resection on the CT image itself. I'll just show the imaging features which are more worrisome actually.
Actually, for LIRADS, I would like to say that LIRADS is only applicable in cirrhotic patients. It is not for any other lesion. Cirrhosis or chronic hepatitis B.
You fit this guy on LIRAD 4?
5, ma'am.
5.
Because it is showing all the ancillary features, diffusion restrictions, washout, which is major criteria.
Only in that spot within.
Within, yes, one nodule.
One nodule.
And also on MRI, it is showing a capsule enhancement, which is mentioned in the report. Unfortunately, we don't have the images to confirm that, but it is in the report.
Capsule vascularity on my ultrasound. Very, very
So
well demarcated capsule vascularity.
The presence of a capsule itself is a high diagnostic criteria for hepatocellular carcinoma.
So what are the patients of FNH which can be observed? Which is that subset of patients where we don't do anything, we diagnose FNH with confidence without biopsy and we observe?
In characteristic features.
All patients of FNH we observe.
No, he's talking about cirrhosis.
Truly means, we are confident that these patients are FNH.
See, one study that I quoted, if 3 features, size less than 1.6, presence of a fibrovascular scar, no diffusion restriction, no portovenous washout, this can be confidently labeled as an FNH and can be, but still needs to be observed in a cirrhotic patient. A cirrhotic patient near yearly surveillance, irrespective of whether he has a lesion or not. In case they have a newly diagnosed FNH which had not been previously seen, we will still keep it on 3 to 6 months follow-up with tumor markers and with imaging.
And there should be radiopathological concordance. If there is any discordance,
usually FNH is not targeted for biopsy. Usually where there is imaging characteristic favoring FNH, it is not targeted for biopsy. In this case, the biopsy was done because radiology was more in favor of an HCC and the alpha fetoprotein was normal.
Usually the tumor doubling time is around 4 to 5 months.
Yes.
So between the previous PP and the one which was done yesterday MRI, is there any change in the size?
I will check because the MRI only one sequence was taken. I can check the size.
Because it grows
Very rapidly, yes. And even in this case, as it was not seen 1 year before, so in 1 year we have a new development of a 6 centimeter lesion. This is also worrisome.
Also, the patient is having mileage, weight loss, and increased appetite, which FNH.
The only criteria going against HCC is AFP. Otherwise, imaging-wise, it is more in favor of HCC.
AFP can be normal in fact.
Yeah, and there are case reports where AFP was normal and radiology was strongly pointing towards HCC, histopathology was pointing towards FNH, and eventually the lesion was resected. But those patients on the imaging, there was no right or left lobe disconcordance that we see in this patient. So he is more complex because he is showing atrophy of the right lobe, which is the reserved lobe.
His left lobe is almost the same size as the right.
This is the umbilical figure. So this lesion is in segment 3. And there is some doubtful, whenever we want to resect, we can't resect here because we need to give adequate margin. This is the gallbladder. So his middle hepatic vein will be at the bed of the gallbladder. So when we resect, do a classic left hemicolectomy, we leave only this much of the when we do hepatectomy, left hepatectomy, hemihepatectomy. So this lever will not be sufficient to take over. So suppose if we still contemplate liver resection instead of transplant in this patient, ideal way to go about is this is supplied not by the main hepatic artery, it is supplied, it is getting axillary hepatic artery from left gastric.
Left gastric.
So we have to do transarterial chemoembolization of left gastric, supraselective embolization, and then same time we have to go with portal vein embolization of the left portal vein. The problem,
This is the arterial supply. It's coming from left gastric.
It is coming from the left gastric. Even after portal vein embolization,
aberrant supply also.
Yeah, aberrant. So all the complications are there.
normal liver anatomy we only see in 30 to 40%. So the rest to 60% will always have some abnormal anatomy. So if this part of the liver does not grow after portal vein embolization, he will be a transplant candidate. There is no ambiguity in that. The problem if we do only portal vein embolization is tumor is always supplied by hepatic artery. So buffer mechanism increases the blood flow to hepatic artery and chances of metastasis will be very high. So we have to do first transarterial chemoembolization, then go for left portal vein embolization, wait for 2 to 3 weeks, see if this liver expands by at least our desired future liver remnant, then we can contemplate resection.
How much expansion do you want before you say I'm safe to resect?
At least 20% we
20%
20% increase suggests that patient has a good regeneration.
And over how long of a period of time? 3
Around-
months? 4 months?
Around 2 to 3 weeks.
Okay. Now, the patient decided to seek second, third, fourth opinion, so he sent all these images and the biopsies we gave him to Germany to a surgeon, and he said the surgeon answered him, come, I'll just take it out, there is nothing about it. And the patient is convinced, I'm going to go and get it out and come back feeling well. I said, don't go for a crazy resection before you assess the rest of your liver, because you'll end up with hepatic decompensation.
One thing we can consider is non-anatomical resection, parenchymal saving, just remove only the tumor part.
Itself.
But
And
we
all-
always chance, there is in malignancy HCC, there is always intraportal shunts and chance of small satellite lesions are very high in the same lobe.
And actually, there are 2 tiny areas which were mentioned in the liver MRI also. Although they are too small to be characterized, but there are 2 tiny cystic areas in the left lobe only, apart from this lesion. One can be seen here also.
Meanwhile, by the way, all of these information was given to the patient with a very clear discussion that I cannot call you benign yet. I can only say that the biopsy showed benign, but doesn't mean that we got the full diagnosis. That I would like to see you in close follow-up, so we scheduled to come the second week of August for a study. By that time, I think we'll get some ultrasound contrast.
Hopefully, ma'am, we'll try to arrange.
Can we arrange it? Ultrasound contrast is very useful, even at abdominal ultrasound.
But will it change the
Yes.
management? It might not change,
It
madam,
may-
irrespective of the result.
It may, if it shows you total washout of these nodules,
It will convince us
it will
more
convince us
towards
that this
surgery.
is XCC.
Yeah.
Because 2 nodules are inside this nodule, so it may be FNH in the periphery with 2 foci of hepatitis.
Suppose if it doesn't show washout, still we have to go for surgery, madam. So that will not change the management.
So when I see him in August, we'll see what the ultrasound will tell us. Plus, I think we offer him embolization of the
And one
blood
more
supply.
thing, just in case we are pushed to surgery, we can try to do only segment 2 and 3 up to umbilical fissure and take a chance with the margin.
But if you go in surgically and you find the margin involved, you will be stuck in the middle of surgery of a decision. Because you may see the margin.
We have to use, non-anatomically we have to shave off, man. We have to shave off instead of taking at the vascular level. Instead of anatomical resection, we have to go for parenchymal saving, non-anatomical resection with the help of intraoperative ultrasound. In high-risk cases, that is the only, because usually if the patient is listed for transplant, they don't get immediately. There will be a waiting list. Sometimes to buy time, we do a palliative resection, something like palliative resection. Just take it out, debulk, and then he might be a candidate for.
Meanwhile, I ask the patient to stop smoking. I refer them to smoking cessation management with Dr. Jakir, because hopefully we can improve also his general condition. If he is to undergo a major surgery, his lungs hopefully will be better. We also have to deal with his coronary disease and with his anticoagulants. He's very pessimistic. He said, my father died at this age, I'll die at this age, and he's carrying on severe depression once this lesion was found in his liver, even before coming to us. These are the situations I face with patients where we cannot give a definitive diagnosis. It's painful more than a definitive diagnosis.
I think in this patient we have to always err on the side of malignancy, irrespective of whatever the biopsy, whatever the various imaging findings are there.
I agree.
And imaging is strongly pointing towards
Yes.
SCC. So
Imaging points towards it. Histopathology, which was shared with 3 pathologists, Dr. Abid, Dr. Abdullah Darwish, and Dr. Mary Jane, said this is benign. But again, I'm saying I'm not sure this abnormal looking nodule inside the nodule was sampled.
and coexistence is also seen in
Yes,
large
correct.
lesions.
And sampling error in a big lesion is a fact. You can have sampling error because depend on the angle of the needle, whether it hit that nodule or it didn't. I don't have documentation, unfortunately, of whether the needle went through that nodule.
And in ultrasound, it will be difficult because he does not have only one nodule. He has many nodules. The one which is superior most is showing a washout,
With
not the
EUS
others.
With EUS
Yes.
you can target.
With EUS, yes,
Very
it can be
carefully
targeted.
You can target. You can get a needle within even a centimeter because your trajectory is clear and you can get it. But EUS carries a risk of infection higher than percutaneous.
But will further investigations change the management, ma'am?
I think so. I think
Because
it would.
even if we cannot prove malignancy
Yeah.
by further investigations, we have to go for surgery.
Laparoscopic good biopsy, you can.
I don't think it, again, the biopsy sampling, Victor, big lesion, 6
Big.
centimeters. Unless you take the whole lesion and you give the whole specimen to the pathologist, he's going to tell you, I'm not sure. He's going to tell
We
you.
have to take the risk of non-anatomical resection if after
I think
portal vein embolization in case if there is no good.
this is what they are going to do in Germany, I
Yeah.
think. Yeah.
No, Germany said, I'll take it out. Don't,
Yeah.
He said, don't